So Dr. Smita Kapoor, would you please start your talk on planning a strabismus surgery?
Good morning, everyone. I'll be talking on how to plan a strabismus surgery. So proper planning of the surgery is a prerequisite when planning a management of a strabismus patient. So decisions regarding the timing, type and amount of surgery to be performed are important, as well as the surgical approach. In order to make good decisions when planning a squint surgery, it is of paramount importance that the surgeon has necessary data available. A history of prior squint surgery may lead the surgeon to choose muscles on which the surgeon may not operate otherwise. In some cases, records are not available, therefore the history is important. For example, if a patient was operated before the age of 1 year, then the likely diagnosis was an infantile esotropia. And then by taking a history whether a single eye was operated or both the eyes were operated, the surgeon would know whether a unilateral recess resect was performed or a bimedial recession was performed. Similarly, a family history can be important in making the diagnosis. Old photographs can give a clue of the initial amount of deviation that was present. Examination of conjunctiva can be suggestive of the type of surgery that was performed, and then the last resort is to perform an anterior segment OCT or an MRI to look for the location of the muscles. Following the history, a thorough motor and sensory examination is necessary to complete the surgical plan. Motility examination includes measurement in the primary position, at distance, as well as a near fixation, in all cardinal positions of gaze, and in head tilt positions. Evaluation of ductions is important to look for any concomitants. Sensory evaluation is critical in planning, especially in cases of intermittent divergent squint, and if high-grade stereoacuity is present, then a tenotomy of superior oblique should be avoided. Monocular occlusion is usually required in patients of intermittent divergent squint to uncover the total angle before surgery. So the starting point when devising a surgical plan is to determine which eye to operate. Factors that determine this decision include the visual acuity and ocular dominance. Patients with poor vision usually will not agree to get operated in the good eye. And if there is a history of any previous surgery in one eye, then the only option that we have is to operate the other eye. And the final thing is that in case of any nystagmus or an abnormal head posture, the goal of surgery is to improve the head posture. So the timing of surgery is also very critical. Infantile esotropia and partially accommodative esotropia should be treated early. For intermittent divergent squint, we can wait for up to 4 years of age. And in paralytic strabismus, it is necessary to wait for up to 6 months before planning the squint surgery. The type of surgery differs from surgeon to surgeon. So for intermittent divergent squint, some surgeons perform bilateral lateral rectus recession, while others perform a unilateral recess resect procedure. And in esotropia, some surgeons prefer to do a bimedial recession and the others do a unilateral recess resect procedure. So the next thing is to do how many muscles to operate. This depends on the preoperative size of deviation. For small angle strabismus, some surgeons prefer to do a single muscle surgery while others do 2 muscle surgery. The benefit of single muscle surgery is that there is shorter anesthesia time, there is reduced risk of surgery, and because only one muscle is operated, then there is the other muscles are left for doing a later surgery. For large deviations, supramaximal recess resect procedures, 3 to 4 muscle surgery, as well as muscle transplantation has been advocated. For small angle vertical deviations, a single muscle surgery can be performed, and for deviations larger than 15 prisms, 2 muscle surgery has to be done. In superior oblique palsy, the surgeon may decide to operate on the ipsilateral inferior oblique, superior rectus, or the contralateral inferior rectus, depending on the pattern of incompetency. Anterior transpositioning of the inferior oblique is done in grade 4 inferior oblique overaction, DVD and superior oblique palsy. For unilateral cases, antero transpositioning should be avoided as it leads to elevation deficit unilaterally. And in bilateral inferior oblique overaction, weakening procedures work best. Likewise, for bilateral DVD, it is better to do an inferior oblique antero transpositioning, and in unilateral DVD, a superior rectus recession can be performed. So the amount of surgery then finally depends on the size of deviation, the duction limitations, the level of fusion. An FDT has to be performed, CNS disease has to be evaluated, and we have to take into account if any history of previous surgeries there. So these are the dosage tables that are used by most strabismus surgeons. And some forms of strabismus need a tailored surgical plan, like in cases of torsion, in which either the oblique muscle has to be touched or we have to transpose the horizontal recti vertically. In incomitant strabismus, the surgical plan is to align the eyes in primary position and also to increase the area of single binocular vision. Decision making will depend on whether there is partial paralysis or complete paralysis. In complete paralysis, transposition procedure has to be performed, and in partial paralysis, strengthening of the antagonist along with release of any restriction has to be done. Adjustable sutures can be planned if the angle of strabismus is small. Repeat surgeries have to be performed, or especially in patients with thyroid eye disease. So coming to the anesthesia, in children and young adults, usually we operate under general anesthesia, while adults can be operated under local anesthesia. Subtenence block is as effective as a peribulbar block, but topical anesthesia should be avoided as it makes the surgery uncomfortable for the patient. The techniques of exposure are fornix and limbal. So in the fornix incision is most widely used as it is comfortable for the patient, and a limbal incision is used for reoperations. So I'd like to conclude by saying that when we plan a strabismus surgery, a thorough history and workup has to be done. This has to be followed by the correct timing, and we have to decide the surgical procedure and dosage. The preoperative as well as the post-op care of the patient are equally important. Thank you.
Okay, that was a great presentation, ma'am. Thank you so much. May I call upon Dr. Gunjan to please come and discuss this?
So a very good morning, everyone. I'll like to, very nice presentation, Dr. Smita, and I would like to add some points. First of all, as she has pointed out very rightly, that lateral incomitance should be taken care of while operating on a case of exotropia. Similarly, true divergence excess patients have to be explained about the need of +3 glasses, which they might need in the postoperative period. Secondly, patients who have had a history of road traffic accident and have then presented with exotropia may have fusion disruption syndrome also. That has to be taken care of, and patient has to explain, we have to explain to the patient that he might have persistent diplopia even after the surgery. Then large resections must be avoided as they may cause globe retraction. Similarly, large recessions can cause appearance of pseudoproptosis and widening of the palpebral aperture and has to be avoided. Third thing, we should not induce any incomitance. So the maximum amount of surgery which we perform usually is 6 mm for the medial rectus and maximum 9 mm for the lateral rectus. See, ultimately it is how much dissection you are doing, how well the dissection you are doing, and that is to be titrated and varies from surgeon to surgeon. No particular table or no particular things exist which can tell, and you have to titrate your surgery with time. FDT should be done during the surgery as you are performing the surgery, and each step of the before and after each step of the surgery, FDT should be performed, especially in cases of paralytic squint. What we have been taught is that symmetrical surgery should be done for symmetrical squints, and asymmetrical surgery has to be done for asymmetrical squints. That means a patient, if he has exotropia, which is there only in one eye, like sensory exotropias, we have to operate on that particular eye only. And if there is alternate divergent squint or an intermittent divergent squint, then a bilateral surgery is what we prefer. Then another important thing is size of eyeball. So, and the age of patient. So if you have a patient who is younger in age and the axial length is also smaller, then even small amounts of surgery which you do can cause a bigger result. Like if you are doing in a child, even a 3 mm or even a 5 mm recession can produce an effect of 6 mm recession as seen in an adult patient. So that is because of the variation in the size of the eyeball, the length, axial length difference. And in patients who are having high myopia, one has to rule out strabismus fixes, especially if there is a limitation of extraocular movements also. So an imaging should be done for the same. Never miss a pattern or an oblique overaction, because that can result in a residual squint, and the patient might come back again with a residual pattern. I think other things she had covered. So thank you.
Thank you. And you had put it in a nutshell, the whole thing. And she had mentioned about the CNS abnormalities. In a CP child, you should be careful, and we should not go and intervene early, because you can land up with other consecutive XT or something like that. So in CP child, we should be extra careful. And the muscles are also not the same way as it responds in the normal children.